Good evening, ladies and gentlemen, and welcome to our educational program. Today is March 25th, and 2020 and the world is in a global coronavirus pandemic. All corners of the world are dealing with this issue. And here we have invited to our studio Dr. George Melikian. Dr. Melikian is an infectious disease, board-certified infectious disease specialist, as well as an internal medicine specialist, who currently is on the front lines dealing with the surge of hospitalized patients who are infected with this virus. It's very important that we note that today is March 25th. This information is changing on a daily basis. So if you are watching this, make that note. The numbers that we are going to present today and the information and the advice that we're going to present today are good as of today. That may change any day now. Dr. Melikian, welcome to our program.
Thank you very much. Nice to be here.
So, unfortunately, we're here under some dire conditions, but it is important that, I know you have been busy. We have chatted several times over the past few days, and I've seen that you truly have been inundated with consults in the hospital and dealing with what's going on. Perhaps maybe we could start from the basics, and maybe you can tell exactly what is the coronavirus, why are we here? What happened that brought us to this moment that we are now?
Sure. So coronaviruses occupy. They're in a branch of respiratory viruses. There's four primarily that are classically known to be circulating as cold viruses, and then there's three other ones additionally that some of our viewers probably have heard of. MERS, that's the Middle Eastern variant that recently was in epidemic state, and the SARS coronavirus, which was in 2003, I believe. This coronavirus now is an evolution. It's from that same family of viruses. The virus itself, to be technical, it's a RNA virus, much the same as, for example, HIV. Of course, totally unrelated, but the same kind of
same category.
Same category. The interesting thing about coronavirus is, number one, why do we call it coronavirus? Because the virus itself looks like what the corona radiata of the sun. It has these pegs, they're called spike proteins, all around it, and that's where the name corona comes from. The virus itself is known to come from various animals, not always bats. In this case, this one specifically has a reservoir, a progenitor reservoir that are bats. There's another very commonly circulating strain called the Netherlands 63 strain, which is very similar to this one. That one is not pathogenic, doesn't cause the amount of disease as this one does. Most of us have probably been exposed to it. That one is almost identical, and that one comes from bats as well. So that's a little bit of a background. In summary, they're responsible for respiratory infections, and the reservoir where they come from usually are animal species.
So it appears to be that they come from an animal, and they don't infect animals, so they can, multiply, or they don't make animals sick for the most part.
They don't make animals sick, correct.
So hence but when they infect humans, then we are the ones that get impacted by the disease.
Correct.
Now, how about this specific one? I mean, we've heard, what is widely believed that it started in an area in China, perhaps through a wet seafood market or an animal market, at least where the first cluster of patients who presented with this respiratory illness started from. And then due to our the way that we travel these days, with open borders, of course, this infection spread throughout China, inevitably to Europe, and eventually reached the United States from multiple angles. Let's come back and talk about what's going on now here in Southern California.
So right now, Southern California, as well as actually the entire United States, but we're in the proliferative phase of this pandemic. Remember, epidemic and pandemic, once it crosses international lines, continents, an epidemic becomes a pandemic. Something that is endemic is any process, doesn't have to be infectious, but that occurs at low baseline levels. Once it goes beyond that, it becomes an epidemic, and once it crosses international borders, it becomes a pandemic. So of this pandemic, we're in this proliferative phase, meaning steady, strong, exponential growth. Some countries, for example, for those who are following, seem to be over the hump. Italy, for example, seems to be slowing down. South Korea, well over the hump. But we here are right in the beginning of it, where the cases are picking up very quickly. And it's exponential.
So let me ask you, coronaviruses in general, they do cause the common cold or portion of the common cold. Influenza virus, again, gets people sick, especially in certain risk groups. We do have surges sometimes, but what is it specifically about this strain or this virus that's making it such a big global problem, both global and, of course, now we have to focus on our local situation?
So to answer that question, we should take a step back. The way that we look at these pathogens and infectious diseases, we try to view them from the perspective of the pathogen, the virus. From the successful viruses are the ones actually, or bacteria, but let's just talk about viruses. Successful viruses, speaking from their perspective, are the ones that are able to infect a host, then move on and infect another host. If a virus is very pathogenic, is able to kill the host immediately, keep in mind the virus will die with the host. And that's why we won't see pandemics of, for example, something like Ebola. Ebola kills 80-90% of infected hosts. Well, what makes this coronavirus particularly dangerous and quote unquote, I guess in a way successful, is that it is extremely infectious. It's able to infect other people very quickly and with minimal exposure. So there's this variable we call R, which we follow, which means for every person who's infected, how many secondary infections does that infection produce. There was an article actually just this week in the New England Journal by Dr. Fauci himself. So the estimate for this virus, and this R number, by the way, will change throughout the epidemic, but looking at the original China data, the R number was about 2.3. So for every person that is infected, they will infect an additional 2 other individuals. We follow that R number because ultimately what we want that to be is less than 1, meaning that net it's not infecting an additional host. But back to what makes this virus special, as far as why we're sitting here and why we're all on lockdown, is because it's able to transmit itself very efficiently, and about 20% of folks who are infected, data so far shows 20% of individuals who become infected. It's likely less than that because there's probably more that haven't been tested, but about 20% require hospitalization, and 1% won't make it, will die from this virus. That's several orders of magnitude higher than, for example, influenza. That mortality rate, for example, is about 0.1 or so percent. This is 1%.
Right. Now, is that now when it comes to influenza, most cases of influenza are diagnosed, so we know what we're dealing with. Is that correct?
Correct.
So, which brings me to now, let's talk a little bit about, how does this condition present, and what are the modalities that we have currently available to us to diagnose? Of course, keeping in mind to our viewers that, if you're watching this in a different part of the world, this may be different in terms of what modalities you have available to you in terms of diagnosis. So what are the presenting symptoms of this condition?
I'll start, before I say that, I'll add one more thing to that. The signature of this virus that's particularly different as far as the epidemiology, who gets sick than influenza, is this seems to really target folks who have underlying cardiovascular issues, heart disease, hypertension. They tend to do worse, which isn't the same with influenza. Influenza, folks with underlying respiratory disease and immunocompromised folks did worse with influenza. The other thing that's different about coronavirus than other respiratory viruses, or particularly influenza, is that it really spares the young, especially infants. Actually, there have been no reported, this was again from the New England Journal article this week, that no cases from the initial China epidemic, no cases of infections for anybody under 15 years old. Now that doesn't mean that they weren't infected. It may mean that they could have had something very, very mild and never got tested.
Right.
But that is drastically different than coronavirus, influenza, which does affect the young, pregnant females and the very old. Now back to with coronavirus. Here we're looking at the brunt of it. The population most at risk is the elderly. Higher the age, the more, but generally age 65 and greater. The presenting symptoms for this infection, if I could describe it, is fever and dry cough. There's other symptoms, for example, pain, myalgia, headache. Those are less reliable, but they're often there. But fever and dry cough seems to be the signature, which is different than the common cold, which is usually most people will have a runny nose. Runny nose is not a feature of this virus.
So fever is the most prevalent symptom with this, and then a dry cough. Now, I have been reading and keeping up with the data, and it seems that unlike other cold, or unlike other serious coronaviruses like SARS and MERS, that patients who get infected with this coronavirus can actually be infectious prior to developing symptoms.
Correct. So there's still studies coming through. It's not entirely, generally, let me take one step back. Generally for respiratory viruses, the infectious period is usually 24 to 48 hours before an individual, the patient starts having symptoms. That's usually when they're shedding virus around. It's estimated so far, at least from the data, that this is maybe a little bit more, maybe 3 days or 4 days prior to that, but that patients are shedding virus. But the amount of virus that is being shed is tremendous. There's a lot of shedding, and this is really unusual because for respiratory viruses, like what we're talking about earlier with influenza, most of the main route is through the secretions. And we often tell patients when they ask, well, when am I not infectious with the common cold or even influenza, and we say, well, when your secretions dry up, because that's actually through evolution, that's how viruses spread themselves. Mm-hmm. But in this case, the secretions are not involved because it's a dry cough. It's mostly respiratory. It's also passed in the stool. However, so far they've seen it in the stool, the virus, but they haven't been able to culture it, meaning it's not clear whether that's alive.
Infectious or not.
Yeah. The remainder is likely droplets, and somebody coughs, aerosolizes into the air. And it's important to keep in mind it's not the immediate where somebody may sneeze on you or cough on you, but when somebody coughs, that virus will distribute itself in the room and land on surfaces and stick around. There is data showing that the virus is able to survive on inanimate, on surfaces, plastic, steel, from 3 to 5 days. In some studies, up to 28, but that's really unusual. But I think for practical purposes, somewhere between 3 and 7 days, which really makes it very infectious.
Right, which goes behind the advice that we have been receiving to wipe down surfaces, of course. And by the way, we did wipe down the surfaces over and over again.
Yes.
Before we actually sat here, wipe down our microphones. But the whole purpose is someone could have walked into this studio and sneezed or coughed or shed virus that may have, floated around in the air for an hour or two and then landed on this surface. And if we inadvertently put our hand down on that surface, picked up that virus, and then went and touched our face, is the way that we would inoculate that virus and hence get infected.
You're absolutely right. Now, just to give you an example of how infectious this virus is, the New York, the epidemic that really started in New York initially was spread by one person who traveled to, I believe it was a synagogue or a bar mitzvah, and that one person infected approximately 130 people. He went to a crowded room and was hugging people. That one was actually studied. It was one of those examples.
And that's where the whole spread started in New York, or
Correct,
were there
correct.
other?
This was the initial.
This was the initial. Wow,
Yeah.
that's
The initial.
so. What are the latest statistics as of today, March 25th, here in Los Angeles County?
So in Los Angeles County, we have approximately 799 infected cases, and I believe it was
13 mortalities.
13
thus far,
mortalities. It's important to keep in mind that these numbers, so people look at these numbers every day, almost like a scorecard, but it's important to keep in mind that these numbers are based on who gets tested. It's not a random sample of the population. We're not randomly, just checking somebody on the street and then seeing if they're positive or not. So these are folks who are going in to get tested, may have reasons to get tested, may not be feeling well, which is actually sort of good news, because what the end result is, it may likely overestimate the
mortality,
the prevalence and the mortality.
Yeah.
Correct. Ideally, what the way epidemiologists look at infections like this is what's called syndromatic surveillance, where you take a step back and you define, for example, in this case, you would define very broadly upper respiratory infections. Let's just say anybody with a cough and a cold, maybe going and seeing a doctor for a cold. You can have a very broad definition, and you can follow that statistic on a citywide scale. So, for example, you could look at Medi-Cal billings or insurance records. This is the type of surveillance that people will do, and then based on that, take a smaller random sample of those cases and see who's positive, for example, for COVID, and that can give you a better estimate for what the prevalence is in the population of those who are, for example, having upper respiratory infections. That's really like a more official, theoretical way of doing it. Right now, what we're kind of problem solving right now, we just want to triage, test, and figure out who needs to be hospitalized, who can go and quarantine at home. So the point I'm trying to get to is that the data that we're seeing doesn't exactly reflect what's going on. We may see a surge of numbers going up, and that may be just from more testing, more aggressive testing, but not necessarily more infections, but likely also a component of which.
Right. So, to summarize, I think what you're saying is that if we do get more positive confirmed cases, a big part of it is that those infected cases are already there. It's just that we're diagnosing them, and hence, it adds to the numbers going up. But also, there are actually people who are infected who are spreading that infection to others. So it's a culmination of both.
Correct.
And And the strategy to which we have been advocating in the city, in the state, and even at the national level and international level, it's been being advocated is to, in order to stop the spread from person to person, is really distancing ourselves, staying home, so that the virus does not have a chance to pass on from one person to person so that it can replicate. And let's say if I had the virus inside me and I isolated myself and stayed home, most likely my own immune system is going to kill that virus, and hence the infection is going to be a dead end. I shouldn't use the word dead, but it's going to be an end to that virus's ability to pass on more virus. Hence the importance of making sure that we all hunker down and stay in for a few weeks, because the people who are infected will either clear their virus on their own or become symptomatic and eventually seek care and be hospitalized and managed that way. And hence we would really minimize the likelihood of that virus to continue to go.
Absolutely. And if I can add something to that as well, the virus, the illness that we're seeing with this virus, patients usually will have, people often ask, well, how long are people sick for with this, when they're sick with COVID? Generally, mild cases, or the usual case in this case, is about 2 weeks. 1.5 to 2 weeks is how long you could expect for symptoms to last. Folks who have more severe disease, it's 3 weeks. The thinking also with, this is actually guidance from the Department of Public Health here in LA as well, is that we're at a point where we don't think we can stop the epidemic by just doing social distancing and quarantining. We're now at a point where we just want to slow it down, as you exactly said, so we don't overwhelm the healthcare system. So we do just basically just general math on this stuff. We were talking about what I was talking about earlier, that approximately 20%, for example, looking at the China data, 20% of folks who are infected needed hospital care, and 1% mortality. We can divide it up into different groups. What we all really worry about here is if too many folks are infected at the same time. Let's say we're talking 799. Let's say that number went up to 20,000 or 100,000, and then we have 20% of that who need hospitalization. All of a sudden, that can very easily overwhelm our system, right. And folks who need care for other reasons may not be able to, have access. So we're trying to slow that down to kind of spread it out,
right?
So it's not all at once.
And that is a great point. I mean, and that's an example. Like, for example, we have 800 cases now, but let's say, for argument's sake, we had 100,000 cases, and if 20% of that, which would make 20,000 individuals, need hospitalization, then that would definitely overwhelm the healthcare system. 20,000 hospital beds would be Correct. extremely taxing, that's sort of a worst case scenario type of a situation. But
and keep in mind, these are excess hospital. These are 20,000 on top of what the regular rate of people being hospitalized.
That's right.
That's
right, because there are people already in hospitals for various reasons, for other ailments, and
Correct. The endemic rate
and whatever have you. Let's talk about now. We talked about the symptoms. Now, when would one decide whether they should, stay home, or go to the hospital, or contact their doctor? I mean, what are the recommendations now here in Los Angeles County? And also note that those recommendations may be slightly different depending on where people are watching or what municipality or country they're in even.
This, the infection that this virus causes has a particular signature. Generally, people have symptoms, meaning what we were talking about earlier, which is the dry cough and fever. And these last approximately 8 to 12 days. Somewhere between that 8 to 10 day period is where we see if somebody's actually going to have a bad outcome, meaning get very, very sick. It often occurs at that 8 to 10 day period, somewhere down the line. So it's not immediate. We generally don't see somebody get infected, have a fever today, and then end up in the hospital tomorrow. So what I would suggest as far as if you are at a point where you've had these symptoms for several days, you're short of breath, you're having difficulty, for example, walking across the room, and you're feeling like you're on the way down, it's not getting better. That's the first step, I think, is to make sure to contact your physician or the hospital. Testing, the current recommendations for testing right now, as I was saying earlier, that the goal is now not to stop the epidemic, but to slow the spread. Just going for testing, you will not be tested unless you have any evidence, for example, a high fever or a known contact, or that has the infection, or you're in a group that is at particular risk. For example, if you're immunocompromised or in the elderly group.
Right. So
generally, the young people, for example, wouldn't get.
And that is tested. At this point, the testing is being limited to those individuals. So again, I mean, just to summarize, we talked about the symptoms. If the symptoms are fever and a dry cough, now as the doctor said, that most people, 80% of people, are going to be just fine, and there is a subset of individuals who do get infected who don't have any symptoms. And of course, in the event that symptoms arise, that phase when the symptomatic person deteriorates or becomes worse is somewhere around 8 to 10 days. 8 to 10 days, and that's when, if an individual feels like their symptoms are getting worse, that is the time to truly get in touch with their healthcare provider, their physician. If they don't have a physician, seek the care of an urgent care or one of the community clinics, or if that is not available, and if in doubt, then to contact the hospital first. And oftentimes what we have noticed that in our community, the hospitals have virtual visits, telemedicine docs, where they will evaluate your symptoms and then make the determination whether coming to the hospital is the right place or the right thing for you to do.
The suggestion would be, if you're in any of these high-risk groups, for example, if you're over the age of 60, if you have underlying cardiac disease or immunocompromised, I would suggest, if you start feeling sick, to go get tested immediately in the beginning and not wait until that day 9 or 10.
Right.
If somebody deteriorates, the situation becomes worse, so to not wait that long. But for younger folks, a lot of reassurance that the chance of you having a bad outcome, especially dying, is less than 1%. It's about 0.5%. So just stay home and don't infect anybody else, basically.
Right. So high-risk groups, which is
seek care.
Older underlying medical conditions. Those aren't the ones that we are talking about insofar as just, wait around for your symptoms to get worse. Those are the ones where they need to get tested first, because it would be more important for intervention. Early. Treatment is initiated early. Let's talk about treatment. We have a few minutes left, and I'd like to talk about some of the treatment options. Several questions first. We've read that, don't use ibuprofen, use Tylenol for fever control. What is your take on that?
So there's not a lot of data on this. This is really based on extrapolation to this thing called Reye's syndrome, where there's an interaction, especially in children, where you take aspirin or an NSAID in the context of having a viral respiratory infection and can have deterioration. So I wouldn't say for this, the data really isn't there. If you want to be careful, I guess, but it's not a strong recommendation not to take the ibuprofen. The ibuprofen also doesn't change the course of the illness.
Right.
It may lower your fevers, but it's not going to cure anything.
Right. So there isn't strong data on that recommendation. However, to be safe, you would say stick with the Tylenol. If it's worrying you enough,
correct,
then stick with the Tylenol. Treatments, other treatments that is available to us right now for mild cases, for more serious cases.
So we're in uncharted territory for this. So there is no official, there's no on-label FDA-approved treatment obviously for this infection. But right now, most hospitals, mine as well, we are treating folks who are coming in who appear very sick, who are sick enough to be admitted. We are starting them on a course of hydroxychloroquine or Plaquenil. I could tell you I've had several patients on there, and the results are mixed. I mean, you can't really extrapolate from what my own experience is. I should caution, and what my network of other ID docs I've talked to. But generally, it's been positive. But I want to add that there is data that's going to come very, very soon, because this is basically the whole country is undergoing a clinical trial right now, and we'll have data very, very quickly. So that's one option that we're using. The other is a medication called remdesivir, made by Gilead, which is currently also in clinical trials. This was used for Ebola, which is a very similar, at least the virus is very similar to this, and that is also showing promising results. In this case, if somebody is sick enough, that's the other thing we do, is we can apply to Gilead and ask for compassionate use, meaning off-label. We realize this isn't official, but off-label as a last resort. There are also clinical trials at multiple hospitals. For example, UCLA I know has, and Henry Mayo Hospital, and more. You have to really look that up at clinicaltrials.gov, where they will enroll you if you meet criteria to get, to receive treatment, for example, with remdesivir, as well as other agents, including hydroxychloroquine. But right now, those are the two options we have on the table: supportive care, hydroxychloroquine, and remdesivir compassionate use, or through clinical trial.
Right, and in terms of availability of these medications, are you finding it that in the hospital setting or amongst your colleagues, those medications are readily available?
They're available, but the supply is limited. It's not endless. I don't want to really set off a panic and say no, that we're in really short supply. But if there's a big surge, if we started just handing Plaquenil to everybody who came in and said I had a fever, I think we'd run out. So yeah, we're trying to be very judicious in who we give that to. Again, but the important thing I wanted to stress again is the best time is really before. Remember I was saying that day 8, 10 when people crash, and what I mean by crash is often people go into respiratory failure. It's called ARDS, acute respiratory distress syndrome. When that occurs, from that point forward, it's the chance of mortality is very high. It becomes a different beast, and the treatment alone, as appropriate as it may be, even if we had the official medication, it generally doesn't work very well. So the most important thing is to catch somebody who is on their way down, and catch them early and start them on therapy. Yeah,
that's very good information. Just to summarize, in terms of treatment options, as the doctor said, there seems to be several medicational regimens that seem to be working fairly well. Maybe not for everyone, and it is readily available if needed. However, the best advice that you gave, obviously not to get to that point where those urgent treatments are needed. I guess prevention is the best way to go. Perhaps despite our best efforts of staying in and social distancing, there are going to be some infections. The goal of, which one term that we've heard is flattening the curve. That goal is so that if 100,000 people in Los Angeles are going to get infected, the goal is so that all 100,000 people do not get infected at the same time. And perhaps if the course of this pandemic is that many people will get infected, and I'm not saying that number is the number that's going to occur, but in order to have that the number of people get infected over a gradual time, so that our healthcare system can meet the needs of the people, that 20% who ultimately may end up needing to be seen in the hospital. Dr. Melikian, I want to close by perhaps if you can really give us some, I know we've mentioned it throughout this talk, but some, prevention tips. Some, we always like to focus on prevention. It's the best medicine, of course, let's not get sick. But for everybody who's watching, what are some of the things that you can reiterate for us, please?
So most of the stuff I'm sure everybody's already heard about. Hand washing, cleaning surfaces. Zinc lozenges definitely have a role. They've been studied, evaluated prior to this even for respiratory viral infections. If you have zinc lozenges, they help in reducing sick time. So, and this isn't the kind of zinc that you swallow, it's when you put under your tongue. And of course, wear a mask in public and stay safe. I mean, it's really a matter of isolating and giving it some time for really to get over the curve.
Yeah. Thank you very much, Dr. Melikian. I'm very thankful that you took time from your busy schedule. We will for sure invite you again as your schedule allows, and hopefully we can make this a periodic appearance so that we can best help educate our colleagues, both who are in healthcare, members of the community, both here locally in Los Angeles and all over the world. Ladies and gentlemen, thank you very much for being with us, and we'll be with you during the next episode. Stay healthy out there.